Thank you so much, Dave, for that very nice introduction. I'm very happy to be here today and talk to you about coronal polishing. Uh, it is certainly a subject that's gone through some critical examination within the dental profession, and for many good reasons. We've really evolved our thought process regarding coronal polishing and being selective about what we choose. So we'll go through that tonight, and hopefully you'll leave with some new information regarding coronal polishing that you can take back to your offices and that will help you with that procedure. So onward we go. I'd like to go over some learning objectives that we will cover this evening. We are going to be describing current trends in coronal polishing. And again, I noticed at the very beginning on the survey that a lot of you learned selective polishing during your educations. And I think that you'll all agree that when you did actually graduate and get out into the profession, patients weren't too happy with that. So we'll speak to that change in paradigm shift in what we're doing today regarding coronal polishing. We're going to be discussing the types of polishing methods. We're also going to get into different polishing agents that are available to us. So we can truly select what we use. So the concept of selective polishing is still really in play, but it's more about selecting what we use to polish. We're going to be comparing polishing methods and agents, and we're going to talk about ergonomics. And that from a handpiece standpoint and what's better for us in our careers long term. We'll take a look at how handpieces have evolved over time. And then we're going to finish up with some very important information regarding the CDC guidelines. Certainly paying attention to handpiece sterilization, but also on our personal protective equipment or our PPE. Are we wearing an appropriate mask during these type of procedures that tend to generate aerosols? And then again, as Dave said, we'll end with some questions and answers and give you the link for your CE test. So as I said earlier, polishing is truly a part of the dental prophylaxis, and it is a staple of the dental hygiene practice. Consensus has changed over the years, however, regarding what is best practices. The equipment that we use has really come a long way. I think some of you, I'd like to say more seasoned clinicians, utilized a slow speed handpiece like that on the far left. The far right is the more cordless handpieces that we'll focus on this evening. But handpiece design for the hygienist or the assistant has really come a long way, and the ergonomic changes have been fantastic. So to go over some general definitions of polishing and some fundamental points, the objective truly for the clinician is to utilize the production of a smooth, glossy surface through the use of abrasive particles. So if we have some roughness or some stain or something that's tactile in deposit, we want to use something that's going to get that to a smooth, glossy surface. And that really is the intention of polishing in the traditional sense. Whatever abrasive that we use should be harder than the surface that's being polished. And several factors have to be considered as far as the rate of abrasion, including the abrasiveness size, the hardness, and the particle. So we'll talk a little bit about that regarding coarse polish, cleaning agents, and the differences in those characteristics. Rotation rate. What is the speed in which we're going? You know, oftentimes being in dental education, looking at the students, we'll find that students want to go really fast and utilize too much pressure and really spend maybe a little bit too much time on those tooth surfaces. And we'll go over tonight why those features really add to a little bit of enamel loss, and that's truly what we want to avoid. Again, an increase in any of those factors will result in a higher rate of abrasion and more frictional heat. Frictional heat is an issue for many patients. Certainly those that present with some hypersensitivity, and we'll talk about that, are not going to do well with heat. And those children with those newly erupted teeth and those larger pulp chambers, we want to be very careful that we're not initiating any heat during the procedure. So shifting into this whole discussion, I want to talk a little bit about evidence-based approach. And anything we do in dentistry truly should be embedded in the evidence. Any decisions that we make really you want to look at what does the evidence say about the procedure. So we want to take the best available scientific evidence. We want to use the clinician's expertise. And that's part of the reason you're taking a course tonight, to increase your expertise and your knowledge. But the actual clinical skill is what we mean more so by the clinician's expertise. And you know, there's always room to grow. We know when we talk about the scaling procedure, years ago we were scaling too aggressively. Well, it turns out polishing, we were probably being a little too aggressive as well. So our expertise is always growing and changing, and it's part of this evidence-based approach. Finally, we need to take into consideration the patient's needs and preferences. And what I want you to think about, especially those of you that learn selective polishing during your education period, is that the polishing tends to be the whole picture to the patient. It tends to be the cleaning. It tends to be a big part of the appointment. So that being said, we want to give our patients what they're expecting on some level, but we want to do it wisely, and we want to do it based in the evidence. So each patient is going to present with something different, and we may use different polishing agents with these patients. We might want to be a little bit more careful with our pressure with certain patients. But at the end of the day, it's part of the appointment that they really feel is the biggest part almost. So we want to make it a good experience. We'll talk a little bit about pre-polishing, and I noticed on the survey that not a lot of you are actually doing a pre-polishing, but there's definitely some value to that. And if it can be a good experience at the beginning of the appointment, sometimes you have that patient really where you want them to be, and the whole appointment goes a little bit smoother. So the evidence-based approach is definitely important when we're talking about coronal polishing. So let's step back again and talk about that concept of selective polishing and where it all started and how it began. Truly, the assumption was, or the objective was, to remove stain, period. It's limited to the coronal stain, and it cannot be removed by other methods. So as a clinician, if utilizing ultrasonic scaling, even hand instruments did not remove the stain, then there was an indication to utilize rubber cup polishing. And that is, in essence, that concept of selective polishing. It was based on some research that came about all the way back to the 1960s, and also some research that was done in the late 80s. The research done in the late 60s by Verbeek was about loss of tooth structure, loss of fluoride-rich enamel. Their studies showed that this was happening, and also there was no additional benefit to the patient, and that truly Waring and Horn found out that brushing and flossing removes plaque just as effectively. So perhaps we should just be teaching our patients to brush and floss and not be polishing teeth if they don't present with actual stain. So that's truly the essence, again, of the selective polishing. But we need to look at the research a little bit closer. This study that was pivotal in changing us into the selective polishing modality was utilizing a lab-grade pumice, which is really not for clinical use on a regular basis. The subjects were utilizing 30 seconds per tooth, and that's much longer than we utilize in a regular real-life scenario. Should be doing about 5 seconds per tooth as we move through the mouth. And they were utilizing about 250 grams of pressure, and that's definitely more pressure than we want to be or need to be using when polishing. So all those factors considered, they had about anywhere from a 3 to a 4 microns of enamel loss from this study. But the parameters were not accurate. They were not true real-life scenario parameters. They also talked a little bit about what about that loss of fluoride-rich surface layer, and we talked about that as far as that could be a detriment with polishing. But we know as far as that fluoride loss, that really if you have good, healthy saliva, that remineralization, that uptake of minerals happens on a very regular basis, and truly that isn't so much of a concern if there's adequate saliva. Also, if there's a fluoride treatment or a fluoride varnish given at the end of the appointment, and yes, adults probably need fluoride treatments at the end of the appointment. I know we put that into the children category, but it's a nice service to give our adult patients as well. maybe even for hypersensitivity. But to the point of this particular study, the fluoride-rich layer being lost really was remedied or is remedied pretty easily with a fluoride treatment, even fluoridated toothpaste. So really this was not a concern as well, especially if the saliva is in good shape. But out of that research, the ADHA took the stance and wrote a position paper about selective polishing, and that came out in about 1998. They responded with this position paper saying there's really no benefit to coronal polishing other than cosmetic, the stain removal. And this really stayed in place for quite a long time. As a matter of fact, up until about 2012, that selective polishing was practiced. And the tide started turning when a research study came out in 2011 by Judith Pence. And this study was able to simulate 75 years of semi-annual polishing, the way the methodology did this study. And this study concluded that truly, in a realistic scenario, which we'll talk about in just a minute, there was minimal enamel loss with coronal polishing. Christensen determined from a nationwide sample that was done in 1987 with 29 clinicians, 20 were RDHs, 3 general dentists, and 3 specialists, along with 3 dental assistants, that the standard or the parameters for clinical polishing that most clinicians are utilizing, again, is about 5 seconds per tooth. In this study, a coarse Nupro Prophy paste was used. So in this study, it wasn't a fine or a medium paste. It was actually a coarse Prophy paste. But 150 grams of pressure was utilized and an RPM or speed of 2,500. So if we are to utilize Christensen's findings and utilize these polishing parameters, evidence says to us that there really is minimal enamel loss. As a result of this study, the ADHA actually did a turnaround and changed their stance on it. But again, up until 2012, that's what was being taught, and that truly is not too long ago. It's important to remember that rubber cup polishing is part of the dental prophylaxis, and not only can it remove soft deposits and extrinsic stain, the goal is to create a smooth surface. You know, the focus now is about biofilm removal and making a smooth surface. It's surface energy. And if we can make a very smooth, glossy surface, the less biofilm is going to attach and collect on those teeth. And certainly home care needs to go with that, but there's more of a reason now to coronally polish, and we'll talk a little bit about the agents that we will use with that. So in fact, there are therapeutic products, and that's why the ADHA's stance turned around a little bit, and this was actually found on their website. In light of recent evidence, the ADHA position paper on polishing has been removed pending review. So it's a good thing that it turned around, and it's always important to look at the evidence and change our stance as a profession and grow with it. So things have changed, and we are still teaching selective polishing, but I want to go back to say that it's about selecting what we are going to use, whether it's the polishing agent or the handpiece itself. We need to look at this change in dynamic not as a green light to just use polishing indiscriminately, to not utilize coarse polish on everyone and really do the same repetitive procedure, because if we don't stay within those parameters and we just polish everybody the same with the same abrasive paste, then we could be looking at some enamel loss. So it's about patient selection, it's about assessment, it's about the assessment, diagnosis, and planning, and utilizing the best service for our patients. We need to look at the risk versus the benefits. Care must be taken when removing stain on surfaces such as cementum. It needs much less pressure to cause an abrasion than it would on the enamel surface. Contraindications, as we discussed, newly erupted teeth or areas of any significant demineralization. So we need to go through a thought process of who we're going to use it on, what we're going to use, and that truly is the way that we're moving forward with coronal polishing. Medical history needs to be evaluated as well as with any other procedure. So selection of agents and the technique and instruments are key, because it's not just the enamel that we're polishing. We're looking at, as I said, cementum, And in the two pictures on the far left of your screen, we are working on patients that have recession, periodontal patients. So we want to think about what we're using with these patients. Patients that have restorations, that have beautiful restorative work, veneers and composites. And these days, beautiful composites, sometimes you can't even tell the difference. So we need to be mindful of what is in our patient's mouth, chart that during the procedure, and decide what we're going to use for that presentation. And again, if there's porcelain, we want to think about the luting cement, the margins, and we want to think about primary teeth and what those patients present with as well. So considerations for surfaces other than enamel, let's talk a little bit about restorative dentistry and veneers and that type of thing. Again, if we know what the patient has, if the dentist working within the practice has noted what type of restorative material it is, then the manufacturer will give us an indication of what should be used on that patient. If we don't know exactly what the restoration is, then it's always safe to use what we call a cleaning agent versus a polishing agent. And a good example of that is ProCare by Kerr. And this is a much gentler, non-abrasive type agent that used with a rubber cup will get things clean, remove the biofilm, and create that smooth surface, but not hurt the restorations in the process. So look into that. And again, this ProCare by Kerr is an excellent product to utilize as a cleansing agent. So let's talk a little bit about hypersensitivity and what we have available for polishing agents or desensitizing agents in this arena. Our first webinar covered much more in depth the products that are available for hypersensitivity, so we're not going to be going over that tonight, but certainly we need to do an assessment. And the reason we need to do an assessment is because many people will not even report that they are hypersensitive. To a lot of people, hypersensitivity within their mouth is their normal. So they fail to mention it, and it can be a life-altering thing, hypersensitivity. And if we as clinicians can do something to help that, it's certainly a service that we want to incorporate into the dental hygiene plan, the dental plan in general. There are products that we can use over the counter, and there are things that we can do chairside to help our patients. I know many of you that do polishing have your patients that are reactive, they're sensitive, they're uncomfortable. Not only during the polishing procedure, but during the scaling procedure. And if we can make that scaling procedure more comfortable, boy, that's a huge service that we can do for our patients. And there's a lot of competition in dentistry, and patient satisfaction is huge. So if we can place a step along the way in the process that makes our patients happier and more comfortable, it's absolutely worth trying to do that. Our periodontal patients, about 60 to 98% of periodontal patients have hypersensitivity during the scaling or the debridement procedure. It's a very high number. And many of those patients don't necessarily need to be anesthetized, so they're, I guess, holding on and getting through it. So I want to talk a little bit about some polishing agents that help with this, especially with the hypersensitive patient. It's about the exposure of the dentin. And abrasive agents, such as a coarse polishing paste, for example, can really accelerate and make the problem worse. So if we're just using one polish agent kind of across the board, we can really make those hypersensitive areas even more hypersensitive by affecting those dentinal tubules. We know about that hydrodynamic theory and that fluid exchange. We want to be careful not to make those dental tubules any more exposed. And it's important to note that we want to remove the biofilm. Again, if we end up choosing a cleaning agent that has an extremely mildness to it, what we want to do is remove that biofilm, because in the presence of biofilm, interesting to note that the tubules will increase about 3 times their original size. So those patients that have hypersensitivity, we want to really address that biofilm at the office, but also give them some good home care instructions. So these are some of the players regarding the therapeutic polishing agents that are available to us, and they're what we call pre-polishing solutions. So we have the Enamel Pro, we're going to talk about tonight, just to kind of have a balanced view, the New Pro Extra Care and Colgate Sensitive. Let's look how they differ as far as ingredients and how they work. The whole era of calcium phosphate technologies came about probably about 15, 20 years ago, and the concept was ACP at its core, amorphous calcium phosphate. And really it was an ingenious discovery that we could perhaps help replenish some of those minerals back into the tooth. And could we create something that aided in that desensitization? So calcium phosphate technologies was discovered, and there were some problems, however, as far as having substantivity, having to be bioavailable as far as the product itself. So there was some innovation and development of Recaldent, which we'll look at, CCP, ACP, MI paste. And then another version of this is a Novabin, which is a calcium sodium phosphosilicate. So these type situations should not be widely confusing. We should have a good understanding of what's available to us, because again, these are benefits that our patients should be getting if they have hypersensitivity during the scaling procedure. So they occlude tubules, they form a calcium phosphate precipitate or a mineral-like layer. Again, that ADA Foundation developed the ACP, the amorphous calcium phosphate. Enamel Pro by Premier is an example of a product that has amorphous calcium phosphate. And the only negative per se at all is that it tends to be highly soluble. So as time goes on, if there is an acid challenge, how much bioavailability is there? Another differentiating point with this particular product is that it is utilized as a pre-polish to help with sensitivity, but it is not a product that you would use after the scaling appointment to utilize just as a polishing agent. It's nice if you can have a product that actually does both. But the Enamel Pro by Premier does have the ACP product in it. And many of you have heard about MI Paste or MI Paste Plus. And this, again, has the ACP, amorphous calcium phosphate. But what was added to it was a casein phosphopeptide, which was a stabilizer. And it helped the product have more substantivity, bioavailability, helped it to hang around a little bit longer. So during an acid attack, it was available to help with that, the alter effects of that. MI paste can be used as a pre-polishing to help with sensitivity. It's also a take-home product, needs to be used multiple times a day. And this product also is not a post-polishing agent, so it doesn't have an abrasiveness to it to be utilized after the debridement. The NuPro Extra Care is also an ACP product, and it is also a post-scaling product. So in other words, it's used for pre-polishing for hypersensitivity, but also is utilized afterwards for any stain removal and can be used as the post-scaling polishing agent. You want to apply this with a rubber cup. Wait about a minute before rinsing. The water does not dilute, so you can use ultrasonic scaling with it. It is activated with saliva or water, so you don't need to keep the area dry. There is immediate sensitivity relief, and I highly recommend any products like these that you gather some of the products and utilize them on yourself. Utilize them on your office workers that experience this, because you know, utilizing something like this and having benefit to it, that's going to be able to help you speak to it and help your patients realize what this type of product can do for them. Again, can be used prior to or after the scaling procedure, and it's got polish and stain aspects to it to remove any deposit. Beautiful aspect of this product as well. Several very good clinical trials in the sensitivity relief lasted up to 4 weeks. So 28 days of sensitivity relief beyond that chair time application. So that's it's really a great thing to give your patients. The Novamin is a calcium sodium phosphosilicate, and the silica is actually what is the stabilizer. So when we talked about the MI paste, it was that casein phosphopeptide that stabilized the calcium phosphate. Here with the Novamin, it's a bioactive glass or silica, and that keeps it more bioavailable. The nice part about this product as well is that you do not need an acid attack or pH drop to make it actually kick in and start working. It's always present to help with sensitivity relief and tubular occlusion. The third agent, a little bit different than the last two that we talked about, is the Colgate Sensitive, and that is the Pro-Argan technology, which is a calcium carbonate product. It is a tubule occluding agent. It's for dental sensitivity relief, and it also can be used post-scaling, similar to the previous two products we spoke of. So those are your desensitizing agents or your therapeutic products that can be utilized selectively during polishing. Let's shift gears a little bit and talk about ergonomic challenges. Some of you seasoned hygienists or assistants in the room, or doctors for that matter, recognize that far right handpiece, which is a slow speed handpiece, and we remember using that with a lot of weight to it. Really wasn't ideal for the hygienist and assistant to utilize because of the weight. It really is heavy, and musculoskeletal disorders in general started truly coming into notice in the 80s. Carpal tunnel, thoracic outlet, things like that started really becoming apparent in the dental profession, and a lot of that was linked to polishing, it turns out. So utilizing those heavy handpieces, dealing with that cord drag, and trying to manipulate, again, the bigger handpieces caused us to not have a neutral wrist, and really lended to a lot of the musculoskeletal situations we were seeing. And here you can see the clinician's got a very bent wrist. So handpiece design for the RDH and the assistant became more centered on improving ergonomic conditions. So this is really where we kind of went as far as creating a lighter handpiece. You can see the top one is the Midwest handpiece, and that came out in '96, and that was probably, it was the first hygiene handpiece, if you will, that catered towards a lighter aspect. And very, very important, not only that the weight was considerably different. Actually, the weight from a slow speed handpiece to one of these lighter, newer hygiene or prophylaxis handpieces, almost 60 to 70% lighter than those slow speed handpieces. So great changes. The Midwest, as you can tell, has a thicker diameter, so it causes less pinching. So it causes the hand to be relaxed, and therefore the ergonomic values can go all the way up to the shoulder as far as helping you relax. Another great addition in the whole arena was disposable prophy angles, and not only that, but the contra angle. And you can see on those angles in the center there, rather than having a 90-degree angle, the contra angle has an angulation to it. And although it doesn't appear to be much, boy, you use it and you can feel the difference in getting around those corners with the contra angle. External webbing as well has been extremely helpful to utilize for interproximal debridement. Top picture there, you can see that's a 90-degree angle, and that might be okay for the lingual of those maxillary anteriors, which you can get to pretty easy. And that area has the lowest amount of soft deposit plaque biofilm buildup. Conversely, if you look at the distal layer of tooth number 17, 18, getting around that corner and dealing with that cheek tissue can be a challenge. So these are things that really have changed the handpieces and made it so much easier for the clinician, the assistants and hygienists to use it. Cordless handpieces, boy, that was a game changer. Everything became cordless back about 20 years ago, the phones, etc. And cordless handpieces were really a breath of fresh air. Many of you, I noticed, haven't tried the cordless handpieces. They have evolved. The power is a little bit better. The battery life is better. I highly encourage you to reach out to your representatives, your sales representatives, and try some of the newer cordless handpieces. They are quieter in general than the ear-driven, and that's a huge benefit not only to yourself as a clinician, as far as it being quieter, but also for the patient. Pediatrics, if you can have something that's quieter, certainly that is a plus. So it can be a little bit more of a pleasanter experience. And it's important to note that reduced noise or reduced speed even doesn't equate to less performance. So the speed that we're utilizing should be around the 2,500 RPM range. Those low-speed handpieces that I showed you a few minutes ago, they can go all the way up to 8,000 RPMs, and that's going to cause problems, as we talked about at the very beginning. So it's important to be effective in the polishing procedure and stay within those parameters that we talked about in the Christensen survey. And then came cordless, pedal-free handpieces, and boy, this is a game changer. And all of you that perform polishing procedures, or really dental procedures in general, know what I mean by the frustration of that pedal dance. And you're moving around and you're trying to, especially in pediatrics, keep the patient occupied, and you're looking for that foot pedal and you can't find it. And, you know, it's a dance that you perfect over time. But boy, to remove that out of the picture, to remove that ergonomic factor and that stress, if you will, it's the way to go. So we'll talk a little bit now about pedal-free handpieces. I'm going to talk about two tonight, the NuPro Cordless Freedom and also the iStar by Dental Ease. We'll look at those two technologies as far as the ones that are out there for pedal-free options. We're, as a profession, moving into more off-site practices, more community health settings, nursing homes, and to avoid those cords really is tremendously helpful. The NuPro Freedom Cordless Prophy system we'll talk a little bit about first. It's got smart mode technology, eliminates that foot pedal. It responds to the clinician's touch. That's how it operates. It's intuitive. So as you press a little bit harder, the speed increases, etc. And instead of me talking about it, Dave, let's show them a video on this, how this NuPro Freedom works.
NuPro Freedom Smart Mode technology eliminates the need for a foot pedal by allowing you to control the speed of a prophy angle by increasing or decreasing the pressure of the cup against the tooth. When you press the button on the handpiece, it enters smart mode and the cup begins to spin at a slow speed. As you apply the cup to the tooth, it will spin faster with added pressure. As you pull away from the tooth, the speed of the cup will slow automatically.
Smart Mode technology provides for smooth acceleration and deceleration, plus the ability to maintain a constant speed as desired. The internal processor constantly monitors the system, motor speed, and rotational loads based on the amount of torque. As the hygienist presses or depresses the cup against the patient's tooth, the processor senses the amount of torque, and a specific algorithm in the software is initiated to control the speed of the cup. The NuPro Freedom Cordless Prophy system can reach speeds of 3,000 RPM. It reaches 2,500 RPM with 150 grams of pressure. This is within one standard deviation of the average speed and pressure used by hygienists as measured in the Christensen study.
NuPro Freedom eliminates distracting cords and foot pedals, allowing you to focus on what's important, the patient.
So there you have it. That's how the NuPro Cordless Prophy system works. It really is a pleasure to utilize. And again, the pediatric population, nursing homes, the ability to move more freely, in essence, has been a total game changer and a great addition for utilizing polishing handpieces. One other thing I want to mention is there is an autoclavable outer sheath, and we'll talk about that in a few minutes in more detail, but you're able to actually take off that outer sheath and autoclave that every time. So you're in line with those CDC guidelines, which is an important factor. We'll talk a little bit more about that in a minute. The other one is the iStar Cordless Prophylaxis Handpiece by Dental Ease, and you can see it pictured here. It can also be operated without the foot pedal. It's initiated by pushing a button on the handpiece. So the clinician would hold it and actually slide the hand back a little bit and push it to start it. And also the button will increase or decrease the speed. So it operates a little bit differently, but still in your hand versus utilizing a foot pedal. The unit itself, the entire handpiece is not autoclavable, and I think you're going to find that with a lot of battery type cordless handpieces, but there's no aspect of this particular handpiece that is autoclavable. The handpiece utilizes disposable plastic sleeves to address infection control purposes. So those are the two players as far as really what's out there and available to us as pedal-free options. And what I want to say is that although it sounds great and truly it's the wave of the future, there is a change. There is a learning curve to these type pedal-free handpieces, and I think that it's a good thing to make an analogy to cruise control in a car. And when you get used to that cruise control, boy, you love it. And any of you that take long distance trips, it's so nice to just hit that cruise control and relax. And that's what it causes the body to do, is relax. But you'll find when you initially start doing this that your foot is right there at the pedal. It may be elevated a little bit, but it's still there and the muscles are tense. You have to mindfully tell yourself to pull your leg or your foot back. Same thing with these type handpieces. So there is a learning curve. There's a dance to it that needs to be achieved. And every clinician will have a different experience with it as far as the learning curve. Some pick it up probably right away. But you got to look at your grasp and your stroke when you're making these adaptations. So we'll talk about that in the next slide here. So as far as the technique, when you go back to your offices tomorrow or next week, whenever you do go back, you want to take a look at how you're holding your current handpiece. You want to do your very best to hold it similar to the way that you would hold an ultrasonic handpiece or even a hand instrument, balanced and in the middle. Because if you hold it too far down, what happens is there's going to be a pinching effect. And that's going to nullify all the benefits of using cordless or pedalless for that matter. So you want it to have a nice balanced effect. Again, no pinching, checking the balance, and the handpiece should always be supported. So let's take a picture, take a look at a picture of that. You can see in this picture here on grasp and adaptation, we like to recommend that it is held, the handpiece is actually held in what we call the V of the hand. Okay, so if the handpiece actually sits in that V, it creates a nice balanced effect. That's very important when first learning to use this type of technology, to kind of sit it in the V of the hand as much as possible. You can see in this picture here that the clinician is holding really far down. There's a pinching going on. Even if you can't see the whole hand, you know that you've got a pinch to hold that handpiece in the back end weight of it, if you will. So we don't want to be doing that. That's going to cause unnecessary ergonomic strain, and that's what we're trying to really avoid here. So we want to pay attention to that. Another analogy I like to kind of talk about with clinicians is a Segway. So any of you that have ridden a Segway have had great experiences, and some maybe have had not so great experiences, but it's a balance, and that achieving that balance takes a while. And using a cordless, pedal-free handpiece also is a balance that the clinicians need to come to. So I don't want to overstress that point, but it's worth the ride. It's worth learning how to use that to eliminate those cords in the foot pedal as well. So I want to come down the home stretch here and really focus on CDC guidelines, infection prevention, and taking a look at what we're doing in our own offices, and are we complying? It's important, and it's worth taking a good strong look at. So ask yourself during these next slides, am I compliant? The CDC sterilization guidelines state dental handpieces and associated attachments, including low-speed motors and reusable prophylaxis angles, should always be heat sterilized between patients and not high-level or surface disinfected. So that is right in your CDC sterilization guidelines, and it's pretty straightforward what the recommendations are. Broken down into critical, semi-critical, and non-critical is how the CDC creates the guidelines as far as what is to be used for sterilization or disinfection. Dental handpieces are considered semi-critical. So those fall in the lines that they should be heat sterilized. It's something that we really need to consider and take a look at if we are actually doing that within our offices. There are two studies worth discussing and worth noting. This one was in 2007, published in the Journal of the American Dental Association. Looked at 20 subjects, a lot of testing done. At the end of the day, there were 2 handpieces and 3 prophylaxis angles looked at. Microbes moved to the internal component of the handpiece 75 to 100% of the time. So the conclusion is, unless low-speed handpieces are sterilized after each use, they pose a risk for cross-contamination. We just can't not look at this evidence. The second study, also published in the Journal of the American Dental Association, looked at 2 types of handpieces, 8 brands of prophy angles in certain parameters of use. And again, spores traveled into the motor gears 20% of the time. Bacteria traveled from motor gear to prophy cup 47% of the time. So the conclusion on this study as well is, unless low-speed handpieces are sterilized properly, they may become cross-contaminated. So keep in mind the CDC guidelines are just that, guidelines. So it's really the lowest standard of care, if you will. We just can't ignore this type of evidence. And I know many of you are saying, wow, that's going to be a lot to try to be compliant cost-wise to have a sterilized handpiece each time. So there are options out there. I want you to take a look at a video that discusses how the new Pro Cordless handpiece addresses infection prevention and sterilization. Dave is going to pull that video.
Introducing new Pro Freedom Cordless Prophy System, a cost-effective solution to comply with CDC infection prevention guidelines. Save your patients from the risk of infection and your practice from the high costs of purchasing multiple handpieces. Dispososhield disposable polyethylene barriers for the inner module, simplifies cleaning and adheres to government regulations. The new Pro Freedom Cordless Prophy package includes 3 autoclavable metal outer sheaths that contain a fluid seal, isolating the inner module from patient contact and providing a secure infection control barrier. The system also uses our single-use NewPro disposable prophy angles. Make the move to a more intelligent handpiece. You'll save money while complying with infection prevention guidelines. New Pro Freedom Cordless Prophy System with Smart Mode technology.
So as you can see, it really addresses the issue of infection prevention, of handpiece sterilization, and offers a less expensive alternative regarding autoclaving and sterilizing. Those outer sheaths are tremendously less expensive than having a new handpiece or sterilized handpiece each time. So there's value there for sure. And again, I want you to keep in mind that those CDC guidelines are recognized as the minimum standard of care in dentistry and should be followed. It's important to note that in addition to the CDC recommendation for handpiece sterilization, 11 states have specific language for handpiece sterilization written into their regulations. So I highly recommend you check your state board regarding what that language is and what those regulations are, because it does vary state to state. As far as the inner module of that new Pro Cordless system, a disinfectant wipe is recommended to be used. Again, that's the portion that houses the battery. So most battery-operated type cordless handpieces should have a disinfectant used on them. And some important features are that it is EPA registered with a TB tuberculosis claim. Is it a one-step? Is it a two-step? What is the timing that's needed with these disinfectants? You know, all these things are very, very important. So look at the steps that each disinfectant that's on the market has regarding safety information, shelf life, the quality of the product. But mainly I want you to hear that each handpiece or equipment that you're using, you've got to follow those manufacturers' recommendations for disinfectant. But these are 2 examples of excellent disinfectant wipes that are really great options. So I would be shortchanging you if I didn't spend just a couple of minutes talking about mask etiquette. And I don't know how many of you have seen that scenario on the left, and I tell you, maybe because I'm in dental education, I see that in the on the magazines, and I go, oh! I mean, that is just cross-contamination if we've got anything on our gloves and we're pulling that mask down, but we see it all the time. So that certainly is not a good thing. And if you leave with something that pops in your head, I hope you'll be starting to look at people that wear those masks underneath like so. And then you've got the clinician on the right that probably is wearing the mask like that so the glasses don't fog up. Well, that's great, but really opening themselves up to airborne type situations, aerosols. So we're really defeating the purpose of wearing the mask like that if we're going to wear it underneath our nose. And fit matters. If you look at the clinician on the far left, very big wide gaps, the mask just simply doesn't fit. It's not closing around the nose. You can see the gentleman in the middle, same situation, wide gap. I've seen many clinicians do it twisting with the loops, and that supposedly helps with the fogging on the glasses. And yes, it will help with that, but you're going to open yourself up to exposure on the sides because that air is going to go somewhere, and that's why it helps with the fogging. So size and fit matters, and you know what? Comfort matters. You want to wear a mask that's comfortable. This is a really great mask here. If you can see, it's a very new, innovative design. Sits nicely under the chin, very, very comfortable. But you can see on the sides there's no gapping. So that's important. It's important to try on different masks and utilize a good one that's going to protect you. That being said, there is what we call the ASTM levels with masks, and we should be using an appropriate ASTM level according to what we're doing. So here's a quick chart to look at the different levels of that ASTM. For polishing procedures, an ASTM 2 is recommended. And you can see step by step, if we're going to be doing ear polishing or ultrasonics, we want to then go up to an ASTM 3. So we want to use something that's going to protect us. We're doing this all day long. We want it to be comfortable, and we want it to protect us. So that was a lot to cover on an evening time. We're looking at about close to 50 minutes here, so I want to summarize a little bit and then open it up to some questions. Apply the concepts of selective polishing. Selective polishing is still an option. It's still what we are doing, but we're selecting what we're using and selecting the handpieces as well. Incorporate the recommended standards for polishing parameters. Take a look at your RPMs. If you get a chance to go to a hands-on clinical course, oftentimes you'll be able to test what your personal pressure is. So the safest thing to say there is that you always want to use the least amount of pressure that you need to get the job done. So pushing real heavily is not necessarily indicated, and the softer cups will allow you to get the job done without having to push too hard. Consider the ergonomic advantages of lighter cord-free handpieces. And I know oftentimes the hygienists and the assistants don't have what I like to refer to as the buying power, but boy, your career and your longevity is certainly something to invest in. A lot of times at different dental shows, there's great discounts. Maybe it's worth having a conversation with your doctor and having a representative in to let you try these. Because ergonomically, it's going to lengthen that career if you're not hurting physically at the end of the day. And if it's a great experience and it's lighter and it's easier, it's going to be a happier ending for your patient and for yourself. Remember, the patient remembers the last thing in an appointment before they walk out the door. So if it's a good experience for both of you, it's really going to be a good experience in general for the patient. Utilize proper infection prevention protocols. And I'm speaking about the mask that we spoke of. Utilize the correct mask and utilize one that fits, and try to avoid that under the chin thing that a lot of people do. Comply with the CDC guidelines for proper sterilization of handpieces. Really look into what your state says and make a very strong effort to go with those CDC guidelines and what your state mandates as far as regulations. So I encourage you to take a new spin on polishing. Enjoy the ride and utilize these newer technologies. I think you'll have a great experience. Provide those patients individualized therapeutic choices. I thank you for attending and listening tonight. We're going to open it up now to the final screen for your CE information and hopefully answer some questions you might have had during the webinar.
Thank you, Marianne. I want to mention that we've got some links here for some resources real quick in the top left of your screen. If you are using an iOS or if you're using a mobile app to view tonight's presentation, that box is not supported for you. Unfortunately, we couldn't figure out why that wasn't working. There might just be another bug or something Adobe doesn't support. So we will be sending everyone a link with all the links that you'll be getting very shortly. So whether you can see the links or not, you will be getting the links to the videos and the courses and the quiz. So Marianne, go ahead and answer a handful of the questions that we got.
Okay, excellent. So we have a question here. What is the battery life of the new Pro Freedom handpiece? Excellent question. Both of the cordless, pedalless handpieces I spoke of tonight say that they have an all-day, what we call an all-day battery life. So it should go through about 10 prophylaxis, polishing, 3-minute procedures. So all-day battery life. The new Pro cordless will do a 15-minute quick charge, and it won't give you the full extended charge, but it will allow you to continue if need be. So that is the answer to the battery question. I have one. Is it okay to apply varnish after using, sorry, that one kind of blanked out a little bit. Is it okay to apply varnish after using, and I'm assuming it's going to be, it cuts off the question, I'm sorry. I think it's probably you're asking after the therapeutic polishing agents, and yes, it is. It's fine to use varnish after that, after you use the therapeutic polishing agent. Truly, yes, that's the question. Thank you for repeating that. It's fine to do that, and actually the patient's going to get a double support of desensitizing benefits. Great question. Are the Profi angles for the new Pro Freedom handpiece more expensive? I think that says. I think you probably would need to check with your representatives. It is a closed system in that the angles are unique to the system, so you would need to use those angles that go with the new Pro Cordless Freedom. On the iStar unit by Dental Ease, I believe you can use different prophylaxis angles. But as far as price and specifics on that, I would highly recommend you check with the manufacturer. Okay, I have one here on ASTM levels, and I'm going to ask my friend Patty to come in on this one. If you want to unmic, Patty, do all masks show their ASTM levels? That's a really good question. Patty, you want to jump in on that one?
Yeah, actually, Marianne, you need to check the box that your masks are coming in. You can usually tell if they meet an ASTM level, if you can find the particle filtration and fluid resistance. There's a formula that you can use to find the ASTM level if it's not clearly indicated on the box.
Okay, excellent. Another question, does the new Freedom have more speed or power than the original one? And yes, it does. It definitely has some more power and a better battery life to it. So that's been an improvement, not only the fact that it's pedal-less, but it's got more power to it, which has really been a nice addition. Let's see. Can we use the disinfectant wipes on the outer sheath? Excellent question. We have found that we do not want to use the disinfectant wipe on the outer sheath that we showed during the presentation. We want to remove any visible residue with a warm cloth with just some warm water on it. And again, that autoclavable sheath is going to go into the sterilizer. So you would not want to use the disinfectant on it. You want to keep it nice and free from anything that would cause any problems with it. So just warm cloth with water is all you need on the outer sheath, and then to run it through the sterilizer. See if I have any more questions. So the question is, what is your recommendation regarding polishing of different types of crowns, all metal gold, PFM, zirconia? Again, if you can find out from the manufacturer what is recommended, but you are safe with something like that ProCare by Kerr, which is a cleansing agent. There are other cleansing agents out there. There are discs that you can use, etc. You definitely want to check with the manufacturer, but something that claims it is a cleansing agent versus a polishing agent is what you want to stay with. But absolutely very important to be concerned what to use on these beautiful restorative restorations. So cleaning agent is the best thing I can tell you, and the ProCare is a great product by Kerr. Great questions. So I thank you all. I think that's what, oh, one more. Can you use NuPro Extra Care prior to ultrasonic scaling? Excellent question, and yes, you can. The water, again, actually activates water or saliva to help with that bioavailability and actually helps the product work, helps that occluding of the dental tubules. So excellent question. And yes, the ultrasonic scaling of the water will not dilute it or not cause any negative effects. So great to use with that. Now the question just came in, do you recommend polishing a veneer as well? Again, I would go with certainly what the dentist that placed the veneer recommends, what the manufacturer of that veneer recommends if possible, but you're safe to utilize more of a cleaning agent versus a polishing paste, something that does not have a grit to it, something that's just going to make it a little bit shiny and not have any kind of a grit on a porcelain veneer. But yes, you do want to remove any kind of biofilm that's retained on that veneer to prevent any gingivitis, marginally speaking. I got to thank you, and an excellent presentation. Well, thank you very much. I appreciate you being on. I hope you can make the next presentation, which is in August. You will get a notification on that, and don't forget to take your CE quiz and receive your CE for tonight's webinar. Again, I appreciate you coming. I thank you. Have a wonderful evening. Good night.
Thank you, Marianne, very much. Just a little housekeeping here. Like Marianne said, we have our next webinar will be on August 29th, which I think is a Tuesday, but I don't know now that I'm thinking about it, at 7 p.m. Smart scaling, optimize your treatment outcomes with effective and efficient choices in ultrasonic instrumentation. So I hope you all can attend. We'll be sending out invitations to that where you can register for that one very soon. I'm going to leave this page up so you guys can click through some of those resources if you are using a desktop app and open up your quiz. And I thank you all for attending very much, and we hope to see you next time.